Hi, everybody. I'm delighted to be here. Mary, Mike, and I have put together a presentation that we hope will mirror each other. And I am obviously going to speak from the executive perspective and what it is that I'm looking for in terms of building our professional practice model. And I'm going to focus quite a bit on scholarship in action. That will be a theme that permeates my presentation. So I'm going to talk a little bit about the context for practice and describe just very briefly MedStar Health and the various components of it. Then talk about my vision for our professional practice model, scholarship, translating research into practice, and then really what are the outcomes and the deliverables that I expect in my role of a doctorally prepared nurse leader, particularly in our corporate structure. And please feel free to make this interactive, and we've save plenty of time for questions and dialogue at the end. So a little bit about my scope and responsibilities. MedStar Health is in the state of Maryland and the District of Columbia. We have wide geographic coverage. We touch 1 in 5 of every people who live in this region, so we have about a 22% market share. And our system is composed of 10 hospitals, 2 institutes. One is an institute for research and the other is an institute for innovation. We have 3 home health companies. The Visiting Nurse Association, that's part of MedStar, has an average daily census of over 2,000 patients, and we do about 250,000 visits per year. So there are more patients on the home care role than there are every day in our Baltimore hospitals, is one way to think of it. And we have 4 hospitals in Baltimore. We have a plethora of community-based services that we're really very proud of. Part of our philosophy is making sure that our care is distributed in a way that's convenient for patients and their families. We have 2 managed care organizations. One is a Medicaid HMO called MedStar Family Choice, which began in the Baltimore region, and that is a telephonic nurse case management model of very needy patients. Socioeconomically, they are challenged, and the outcomes of this program really are world-class. Each year in Consumer Reports, that program is typically in the top 25 of Medicaid HMOs. We also have a Medicare HMO in the District of Columbia. We have a number of nursing homes and senior living communities and a very large number of physician practices that are sprinkled around the area. So a little bit about the numbers. Today we have a little bit over 3,000 staffed beds. Those are acute care beds, and MedStar National Rehabilitation Hospital are in those numbers. These are FY12 numbers. We're just waiting for FY13 numbers, which closed on June 30th. So about 185,000 inpatient admissions or observation cases, 3.6 million outpatient visits, and you can see the list going on. We have very busy emergency rooms, and I am an East Coast person who spent a little bit of time in the Midwest, and coming back to the East Coast and really seeing our urban emergency rooms with huge numbers of patients who really should be in primary care practices or urgent care centers was a little bit of a wake-up call. I managed to forget about that a little bit. What most people would not realize is that we have just about 1,000 clinical trials open at any one time across our system, and we deliver about a little bit more than $300 million of community benefit to the communities that we serve each year. And our net operating revenues are $4.5 billion. Any of our operating revenue that's left over at the end of the year is really reinvested in programs, in facilities, and in equipment. It's not that we just sit on that money and have it handy. It really is systematically reinvested. And then a little bit about the people. About 30,000 employees, 8,000 of them are nurses across our system, and almost all of those programs that I talked about have a nursing presence. I would say with the exception of the physician practices, which are very traditional primary care, it would be unusual to have a nurse in those today. But in our specialty programs, absolutely a strong presence, particularly of advanced practice nurses. We have 1,500 employed physicians, and that number is going up both at MedStar and around the country. And then we have about 6,000 affiliated physicians. So that sort of rounds out what we're looking like right now. So if we talk about my role and my vision, I'm the first system-level chief nursing officer at MedStar. And this is the second time in my career that I've been creating a role like this. So I am accountable and responsible with nurses across the system for standards of nursing care, standards of nursing practice, research, education, and professional development, and strategy related to nursing in terms of recruitment, retention, salary policy, those types of things. And I have spent really the first 2 years of my role looking at what type of a foundation do we need to support contemporary professional nursing practice. And this is a slide of well-worn concepts. These are really tried and true. The concepts in our professional practice model really emanated from the original round of reputational magnet hospitals back in the 80s and 90s. And we are systematically working through our implementation and addressing each of these variables. So if I think about particularly graduate education at the doctoral level, one of the things that, and this is right from our nursing strategic plan, which ties into our MedStar strategic plan, is a section called Scholarship in Action. And in this part of our overall strategic plan for the whole system, we have a section on knowledge, innovation, and improvement. And all of our nursing initiatives are embedded in that strategic plan. So if you saw a copy of it, you would see the concept, you would see the tactics, and then on other documents you would see my name as the accountable leader, along with people like Mary Michael Brown and our chief nursing officers across the system. So one of the things that we really want to instill and nurture is a spirit of inquiry. And my vision is that all nurses at the bedside, in the clinics, in the patient's home, as well as our nursing leadership group, will bring that spirit of inquiry to their practice. So what does that mean? At the most basic level, starting with the clinical nurses, we would look for systematic evaluation of one's own clinical practice. Now we have something called Talent Manager. And for those of you who are from MedStar, I think there's several of you in the room, it might not feel like we're looking at a spirit of inquiry there. But it really is the beginning of a system that helps us have more rigorous evaluation. Then in our world, we would be looking for the translation of research findings into practice and the contribution and contribute to established programs of nursing research. So what you don't hear me saying is that we're going to have a plethora of nurse researchers on our payroll who are doing nursing research. We really looked for our academic partners to do that. What's embedded in the MedStar strategic plan is that by 2017, we would have a well-recognized and accomplished nurse researcher collaborating in each one of our 5 service lines. And those centers of excellence are the ones that you might expect: care of the patient with oncology problems, care of patient with heart, vascular, and thoracic. And so we have 5 of those. So that's the vision and the pathway for the PhD prepared collaboration. What I don't support and don't want us to be having are a lot of little tiny studies conducted on an isolated nursing unit that do not have a rigorous methodology and are really not contributing to a body of knowledge. So I think Mary Mike knows me well enough now, and I would not be the person to come to and say, I've created a tool or I've created an instrument, because we really wouldn't want to use our scarce resources doing a study or a questionnaire that's really not scientifically based, hasn't had appropriate psychometric testing and that kind of thing. So here's the tactics. Just a snapshot of some of them related to how we're looking at knowledge, innovation, and improvement. The first thing that I did practically upon arrival was collaborate with our Nursing Research Council, which had been meeting for a very long time. And the charges that the CNO Council and I gave them was to evaluate models of evidence-based practice, critique them, and then make a recommendation that could be endorsed across MedStar for what model we would be using. And we selected the Iowa model. The second thing that they've been working on are strategies that support our evidence-based practice and our evidence-based leadership across the system. So some collaboration between and among our councils. And then thirdly, we would want to use appropriate improvement strategies to create a highly reliable organization. And nursing as an island doesn't create a high reliability organization. This is an initiative that is really very broadly based across our entire organization for all disciplines. So if we come back to the spirit of inquiry, and we're really working very hard on this journey for professional practice model, language, assumptions, theories, and models are all really important. And we use our words very carefully in nursing, particularly in the councils, which I'm going to get into in a moment, which are across all of MedStar. So here are just a sample of some of the assumptions that are the foundation for our model. First and foremost, I think it's important to be specific and very clear that the patient and the family are at the center of everything we do. The second point is that nursing is a practice discipline. And I think that leadership and management in a professional practice discipline is really different than leadership and management in IS companies or manufacturing. So there's some basic and very important principles of business, finance, accounting, human resources that we need to lead a practice discipline, but then we really need to understand the nursing component of things and how that looks. Third assumption is that nursing administration is a type of practice. So I don't believe that I gave up being a practicing nurse as I moved into more and more complex administrative roles, but my practice happens to be nursing administration. Fourth, we have a scientific body of knowledge that we really need to recognize and make sure that we're using appropriately. And then finally, this is a very old quote. It was originally written about faculty, and I found it in a book by Boyer, which is now a classic, so I'm sounding old. But Boyer wrote a book for the Carnegie Mellon Foundation, the Carnegie Foundation, on the status of the academy, meaning the university, and talked about the fact that faculty who are more sophisticated and more expert really live in overlapping neighborhoods. So it's not just their own discipline that they're involved in, but they're collaborating and sometimes they're shaping things in other disciplines, and it's reciprocal. It's not one discipline swooping in and saying, do it this way, but it's really what we're now calling, I think this is the preamble to interprofessional practice and collaboration. I believe passionately that professional nurses, beginning with the clinical nurse at the bedside, really practice in these overlapping neighborhoods. And it is part of the underpinnings of why I believe baccalaureate education is so important for nurses as an entry point, because we're looking for nurses to be successful and impact on the lives of very complex patients, wherever they are on the continuum. And to think that we can do that, particularly at the scale of a MedStar organization, without having well-prepared, well-educated nurses, I think is almost a fool's errand. You know, we really need people who are highly competent. The first bullet here, continuing the assumptions, is really based on the work of Patricia Benner and colleagues. And you know, most people are familiar with her first article, From Novice to Expert, published a very long time ago. I think what's important is to read the progression of her work, and this gets into scholarship in action. She's published 4 books with her team, and things have really evolved. And in a prior life, I tortured the Clinical Advancement and Recognition Council. They even joked about it on their slides once. They read every book that Benner and colleagues had written before they designed a clinical advancement program. And when they did their update, we do a twice-a-year update on how the councils are meeting their goals. They had a slide that said, Benner is very hard, particularly book 2. So they had a lot of humor about it, but they did, they designed a richer program, you know, and it wasn't that the directors and I were designing the program, it really was this council that was designing it, and they did a great job. So what do we do at MedStar? We really put scarce resources to offering the baccalaureate and higher degree programs, the clinical placements. We have a very robust nurse residency program for baccalaureate graduates that was designed by the University Health System Consortium Chief Nursing Officers and the American Association of Colleges of Nursing. So what's different about this program? Again, I think it's scholarship in action. It assumes that the baccalaureate grad is coming to practice meeting the essentials of baccalaureate education. So we don't want to repeat anything. And you know, if you try to repeat it, it's very aggravating to the new to practice nurse. Sometimes even when you're not repeating it, they think you might be repeating it. You know, so presenting it in a way that's very respectful of what they've learned in school, but really builds on that is important. We also know from Benner's work that if you do not have a very good first practice experience, you will typically be a nurse who gets stuck at competent. And one of the ways that they understood this was through their critical care study. And the research methodology for that study was to ask ICU and critical care clinical nurse managers and clinical nurse specialists to identify nurses who had 5 years of nursing practice experience who were not experts. So I happened to be at the Beth Israel in Boston in those days with a woman named Joyce Clifford, who was absolutely brilliant and a very forceful leader. So I was explaining the study to her because I was the point person for our site. And she sort of put everything down on her table and she said, well, certainly we're not going to find anybody like that at the Beth Israel. And I thought, oh my. Actually, we found a lot. You know, so once the research team was out talking to our managers, they identified that group of people. Now, there's nothing wrong with being competent, but clearly, I want to create an environment in my organization with colleagues where people really can be on a solid path to becoming an expert. So what did it look like to be competent with 5 years experience versus somebody who was expert? Probably the most striking finding was, and this was a study designed where nurses were asked to write an exemplar of something, a clinical situation where they felt that they had done things well, or a clinical situation that they would have done differently. So, you know, they had a learning built into it. The competent nurses had a very hard time writing those case samples. They had a hard time, tool one, they almost couldn't remember a patient's name. They were not personalized. They were typically pretty medically oriented. If you put that next to an exemplar written by an expert nurse, you really feel like you're sitting at the bedside. You know what the patient looks like. You know what the family looks like. You know the nuances of what makes a difference to that patient. And it's a much richer description of what they do. So Benner, beyond this work, was part of a collaborative in the Bay Area, really looking at knowledge acquisition in a variety of disciplines. So if I asked you, what group of professionals are most similar to nurses in terms of the things that they do cognitively in daily practice? Any ideas? Pardon me? I can't hear. Well, sometimes people think physicians, and that's not the case. Sometimes people think teachers, which isn't the case. Air traffic controllers. So what's similar between what we do and what an air traffic controller does? Safety, critical thinking, and massive amounts of data that you're looking for a pattern in. You know, so how many times do you know, a patient has a deteriorating situation on an inpatient unit, people always hope that nurse so-and-so is on or is going to go in, and they're going to go in the room and they're going to figure everything out in a nanosecond. And it's really not intuition, which is what we used to call it a long time ago. It's really that they've seen the patterns over and over again and they can distill it like that. And that is the underpinning of safety, I think, certainly today. That's critical. So in our world at MedStar, we want to make sure that we're creating an environment based on Benner's principles that will allow nurses at all levels of development to be on a career path where they can move well beyond competent. And that first practice experience is important, and that's why we're in the nurse residency program, because it's built on these principles. And then finally, the last assumption is that our entire nurse executive group, in our system and in others, really design very complex organizational systems that are needed by the clinical nurses for them to have both the authority and the control over their practice to deliver the type of nursing care that they've been educated and prepared to do. And as part of that, they can act on behalf of their patients when the patient is not able to do that. So this is like the background to our journey for nursing excellence in our practice environments. And the last bullet is really important. We do have a collaborative governance model at the system level. We have 7 councils. About 40% of the councils are clinical nurses, and the remainder of the folks are leaders in various roles. Each council has a liaison from our Chief Nursing Officer Council at the system level, but that CNO is there, and Mary Mike is at the Practice Council, not to set the agenda, not to make the decisions, but to be a support in terms of helping the council do their business and also make sure that they have the resources that they might need to carry out their goals for the year. So I called this the right degree for the role. And in my vision, there's certainly a place for both the PhD prepared nurse and the DNP prepared nurse. But I believe that what they do is different. So when I'm thinking about the PhD, I'm thinking about somebody who is really on a strong research path, who perhaps is doing a postdoc, who is thinking about something called a K Award from the NIH, who's doing a pilot study on a more experienced investigator's grant, a P grant. So they're on a path to create new knowledge. This person is probably not going to have the background that we would be looking for to coach our evidence-based practice work. Could they do it? Absolutely. Would it necessarily, but they'd have to be learning some other things, I think, as they do that. Would they be happy? Probably not. You know, so my goal is always to have people be in positions that they have a passion about and are, you know, really productive in. So what would we be looking for the DNP graduate to do? It's really, and I just gave a flavor of it, it's to help infuse scholarship into everything that we do, to drive practice change, and then at some point I think we will find our way into practice-based evidence, not evidence-based practice. It's sort of the next iteration. So that we can discover, and I think the electronic health records are really going to help us do this, what are the nursing interventions that are having the best outcomes for different patient populations? How do we capture that and measure that? So what do I expect? Role clarity. I always think about what position am I filling? And as I have a small number of system level nursing leader roles, this is a really important question. So am I looking for someone who's going to have a hands-on clinical practice? That would be one type of graduate who would bring other things with them. Am I looking really to totally redo education? The answer would be yes. You know, so I would love to have someone who has a DNP with a focus on education, who understands principles of teaching learning, curriculum, measurement, all the things that go into making really robust professional development programs. And then certainly, last but not least, executive leadership. And by that, it could be someone who is on a path to get experiences as well as education to become a chief nursing officer, someone who would want to be in a role like Mary Michaels, which she's going to talk about in a moment, who's driving practice through executive practice at a system level. So I really encourage you, as you think about what you want to get out of your program, think about what track is the track for you and what job you're in, if you're planning to stay in that and be able to do that job with more sophistication, or are you thinking of changing paths? What would it take? The next point is that I really do expect a passion for nursing practice. For folks to be in these high visibility roles that have lots of demands on them, and really not to embrace what I view as the heart and soul of what we all do, which is either practice, clinic, direct care, or support people who are doing that. I think that's critical. And I think you see organizations that sometimes the team looks a little bit tired and exhausted and don't have much enthusiasm. And I learned very early in my career as a nurse exec, if I was having a day like that, I needed to go find a patient care unit and talk to a clinical nurse and a patient and a doctor and sort of just get refocused. A little bit harder from Columbia, Maryland, where we don't have a hospital. But one of my strategies is I just build in that time to be out and about. And then finally, I'm looking for scholarship in practice. So a very rigorous approach to complex issues. Not reading the cliff notes of the important articles out there, but really taking the time to read in depth and to understand the complexities of what might be in that literature. The second thing is, really in today's world, we're working on things called clinical practice guidelines that are evidence-based. They govern practice across MedStar. We just issued the first 7. We look for folks, colleagues, who can read the literature, know the literature, most importantly, synthesize it, use the various systems that are out there, whether it's the Cochrane Collaborative or a research librarian who's very skilled, to really gather that information. We also supplement that, and I do say supplement, through something called Zincs Health. And we have a subscription with Zincs, and they provide really the knowledge that drives our order sets for physicians and advanced practice nurses, and our interdisciplinary plans of care for nurses and other members of the healthcare team. We actually get from them an update to that, to the scientific piece of their work every 6 months. So what we're building right now is a Center for Knowledge Management that reports jointly to our Chief Nursing Information Officer and our Chief Medical Information Officer. We have 4 people in there. They're all clinicians by background who really can receive those updates and review them and critique them and figure out, is it serious enough that we're going to redo an order set or change an IPOC? Or is it something that's nice to know, but we don't need to make a change yet? Because you think about making a change in nursing practice for 8,000 nurses. It is no small feat to roll that out and educate people. Then, this is the world we live in. Zincs provides a regulatory update 4 times a year. So that's how much our regulatory environment changes. So this Center for Knowledge Development is charged with managing that type of information and making recommendations to the clinicians. And then finally, last point on this slide, really looking to doctorally prepared nurses to role model evidence-based practice and use it whether they're in a clinical leadership role or an administrative role. So one of the projects that I did this past year that some members of our group might remember is there was a lot of discussion in the district about whether we should have mandatory nurse-to-patient ratios. And if you want to think of a topic that would get a lot of attention and energy in a healthcare delivery system, that would be it. So it wouldn't make sense, and I think it would be inappropriate to say the work of Aiken and Burehouse and Needleman, well-designed studies, 20 years of research, was wrong. But what the project uncovered for me is that it was rigorous to a point, and they were large cross-sectional studies. If you go the next level of research and are able to have more discrete measures than they used in their studies, the ratios don't hold in terms of outcomes. That's a really different message to say, yes, this research goes this far, the new research is showing this. And interestingly enough, the new research has primarily not been done by nurses at all. Folks from Carnegie Mellon's economics department did a very good study of the California ratios, and they were able to look at hospital units that had better ratios before the law, and those that didn't, and then the delta, and did not see a significant improvement. And across the board, there was no improvement in failure to rescue rates, although they had improved in general, I think because of the work that we're doing. So that's an example of an executive-based, evidence-based project this year. So I'm almost ready to hand it over to Mary Mike. So here's a picture, which is a metaphor for teamwork, which is going to be the last concept that I want to talk about. This is the 2007 GW crew team on the Potomac, as you can see with the Washington Monument, with my son, the team captain, in one of the boats, which is how I came to have this picture. And in a wonderful academic year, the picture, I have 58 of these pictures, they were taken by a student at GW who wanted to be a photojournalist for his career, and he spent a spring semester on the river with the GW crew team. So I'm going to talk a little bit about this as a metaphor for leadership. If we think about rowing, it's all about excellence, and it is all about very strong practice for a very short race, 2,000 meters, not very long. The other thing about rowing is that boats come in different numbers. So there's a single, then two-person boats are either double or a pair, then the four-person boat is a quad or a four, and then there's an eight. So that was obviously a picture of an eight. Why am I saying that? Because on teams, people go in and out of boats all the time, based on their skill set and based on what the team needs. Some people are superb in a single, and they really don't make it in an eight. In our world, we would call them the individual contributor. You know, they are not the people who chair committees and do work on them, but they are nurses and others who are very good in terms of their work product, but succeed most when they might have a more discrete project that they work on. So one of the things, if we sort of look at the concepts of leading, in crew, there's a coxswain. Now, as a rower's mother, I didn't put the coxswain on the slide. I should be chastised for that. They're the person who's usually very petite and yelling through the megaphone. They're the only person who can see the finish line, because when you row backwards. So, you know, there's a skill to that. So the coxswain can see ahead, and that's an important role. But the person who sets the pace for the boat is the stroke. And I was thinking about this as it applies to committee work, because we spend a lot of time in committees in healthcare. And you want somebody chairing a committee who can set the pace and have an outcome, a measurable outcome, ideally. They also, in addition to setting that pace, really need to motivate the crew and motivate the team members. Then I think there's a role for all of us. We're not always a leader. So yes, I'm a senior vice president and I'm leading the nursing service, but I'm also a member of our corporate executive team, which is 8 people, and then our CEO, really setting the strategic direction for the organization. So in this analogy, I'm in that boiler room or that engine room, because I'm one of my colleagues and my peers really trying to keep things moving and have a lot of energy with it. We follow the lead in that role. When you do a literature search, and I haven't done this recently, but last time was a couple years ago, if you look up followership, there's not a real robust amount of literature there, but I think there's really a skill in being a good follower and being able to support colleagues. And I think today we go in and out of all of these different roles. Then there's somebody, last seat in the boat, usually the shortest person on the team. That would be my son at 6 feet. So these are usually tall people. He was always the bowman. You know, and they're the first one across the finish line, and they are also trying to steer the boat. So an important role for them as well. And then what about the team together? And for those of you in the executive track, there's a wonderful Harvard Business School case on the Army crew team that came out a few years ago. Crews are very metric driven. So there's rowing machines called ergs. You get a time, gets posted, feeds into what you're doing. There's something called seat racing. So each week they systematically move rowers out of each boat to see who makes it go faster. So if you go from the A boat to the B boat, and my slide had both, you know, not a bunch of happy campers typically in the B boat because they want to be in the A boat. So the Army crew team study is about the A and B boats, because their A team was absolutely put together on metrics. Height and weight and ERG scores and how far they could run and a variety of other things. And the B boat had the people who didn't make the cut on one of those variables. But every day before they went out on the Hudson or wherever they were rowing, the B team pretty much had an attitude and a chant that they had absolutely nothing to lose because they weren't in the A boat. What do you think happened? They beat the A boat every day. So it really was, it's a nice case that really helps you look beyond the numbers. And I think that's important because we are really focused on metrics these days. So the final thing about a crew team is that they really do support and challenge each other. So they're competing within the team. But one of the things that makes or breaks a boat and a team is trusting your team members. Because if somebody goofs up a stroke and the boat overcompensates, they really get in trouble. So it leads into this notion of trust, that that person will self-correct and the boat will continue to move in the direction it's supposed to go on. And also, the team plays to everybody's strengths because not every person has every single strength that an organization needs. I think the challenge for us is to have teams that are balanced. So to have somebody who's concrete and very attuned to details, maybe somebody who's a more abstract thinker, but can also pay attention to details, but really looking to compose a team that has a variety of skills that the organization or the unit or the program or the project really needs. So a little bit of levity with the crew team, but I think it gives us a lot of food for thought. So with that, I'm going to turn it over to Mary and Mike, who is going to talk about the student perspective. I think we should have put graduate perspective on this, now that I'm thinking of it.
Well, I'm incredibly happy to be here to talk to some of my favorite people in the world, and that's Doctoral of Nursing Practice students at GW. And I'm very pleased to have listened to Maureen's talk because I learn more and more each time I hear Maureen talk. And what she provided us with was really a blueprint of what a chief nursing executive is looking for in a DNP prepared nurse. And what did you hear her say? I heard an incredibly, a scholarly approach to everything that we do, to critically appraise the literature, to use data to drive decisions, and to translate research into practice to improve patient care. So I thought what we could talk about this afternoon is how you get from where you are today in orientation as a DNP student to graduating. Some of you are second years, might be 2 years from now, 3 years from now. Some of you might be a little bit longer, 4 years from now. I don't know, is Carolyn, where are you? I was talking to Carolyn earlier, there you are, was telling me she's got kind of a longer journey coming in as a BSN to a DNP. But I want to talk to you about how you get from here today to graduate and then be able to utilize all the skills that you've learned in this program so that you can practice to the full extent of your education. So how are we going to do that? Well, I think one of the first things I want to talk to you about is leveraging your professional experience in your coursework. I want to talk to you a little bit about leveraging your coursework in your professional practice setting. I want to talk to you a little bit about developing and identifying mentors. I want to talk a little bit about networking. And then in the spirit of academia, Maureen and I have done our homework, so we asked 4 DNP students from MedStar Health if they would advance some questions that we can address, so we're prepared to do that. And then lastly, we'll take questions. Okay, so this is the interactive part, and I'm quite serious about it, and I know your names, and I'm going to call on you if you don't react. I would like to know what prompted you to enter a DNP program. I really would like to know. Yes.
I took a new position, sort of not really a career change, but a bit of a change about 3 years ago, and ended up working, in my opinion, in a very archaic med organization, and so I have this drive to improve it because it's so incredibly inefficient and it really affects patient care.
So your belief is that a Doctor of Nursing practice degree will help you improve patient care based on the curriculum that you're going to master.
Yes, then also give me the sort of title or the ability to influence other people.
Okay. Okay. Others of you, why have others of you decided to go into this program? Yep.
I wanted to have that title behind me to implement change at either government or organization level. And just with my master's degree, it didn't seem feasible at that point.
So you wanted some academic muscle and parity behind you. Okay. Oh, go ahead.
Oh, I was just thinking my hand.
But now that I see you. How about if I switch the question? What are your career goals?
It has to start with that last question.
Okay.
You know, I've been a nurse for 25 years, and I've been a nurse practitioner for 23 years. I wasn't a staff nurse for very long, and I've had a love-hate relationship with nursing my entire career. I love what I do, but there's a lot of things about the nursing profession that really frustrates me. And it wasn't until recently, which I find kind of odd, that our hospital is going towards an integrated system with a lot of mid-level providers, and they're making their own physician group. So a lot of physicians in the community are joining the hospital and being employed by the hospital. And the nurse practitioners and the nurse anesthetists that are already at the hospital and employed by the hospital, they're kind of batching us into that group with physician assistants and physicians. And it was kind of portrayed to us as like back in the colonial days, join or die. And I remember sitting in a room one day, and they walked in and they gave me a binder with all the great stuff that they can do for me, and they threw a long white coat at me and said, "You're now part of the physician group." And I sat there and I went, you know what? That was the first time in 25 years that I actually felt that I was a nurse and I had to stand up for it. And I said, this is it. It was a pivotal point in my career. So you can throw a white coat at me and put the physician label all over me, but I don't care what you do, you can strip me down, I am a nurse. And at that point in time, I made the decision that, you know, I need to set an example for all these other nurses here, that we're the backbone. And everything that goes on in this institution or that institution, it's what nursing is. We hold it up. And whether you're a mid-level provider or you're a staff nurse or you're a nurse's aide, I mean, we provide the foundation of everything. And I have to work collegially with physicians and physician assistants, and I do, and I have great relationships with them, but it just seemed like the next step for me. So it was a big, huge epiphany for me.
So it sounds like, too, that you're pursuing your Doctor of Nursing practice degree to practice at the full extent of your ability, as well as to have a credential that would give you some parity.
And I want the nurses around us to see that it's not an endpoint.
Right. Some of the other questions I'd like you to be asking yourself are, what are my key areas of interest, particularly for those of you that really can't answer the question right now of what are my career goals. Most of you probably can give some answer as to why I've gone back to work on a Doctor of Nursing practice degree. And I'd like you to be thinking about what are my key areas of interest, because that's going to follow you throughout your curriculum. And it's A-okay if you can't say, here's exactly why I'm going back to school, this is my 5-year, my 3-year plan, and this is exactly my interests. Loomis and colleagues did a survey in 2007, and 69 nurses replied on why they would pursue a DNP in nursing. And the number one reason was that they were looking for increased intellectual knowledge, and the second was career advancement. And for me personally, I was a director of an outcomes department, and I knew that that wasn't the penultimate location for me to reside in, ultimately. So I went back to school, quite frankly, because I was looking for the intellectual challenge, and I certainly found it. I also queried the DNP online community, and there was actually a discussion in July this year, and a nurse practitioner who had finished her DNP said, look, I knew I didn't need my DNP to maintain my career. I did it because I wanted the personal and professional growth that was associated with the DNP. And I think that all makes sense. Boland and colleagues said that prospective students should have a good idea of their area of interest or where they see their future careers. And I would highly suggest you think about that as you're driving home or you're flying home, because you need to have some idea about how you want to apply the hard work that you're going to be putting in this program. Now, a word about the dream job. You know, as I mentioned, I was a little hazy on why I went back and got my DNP. I just told you I really kind of didn't know exactly what I wanted to do. And I did harbor a very tiny idea that maybe when I finished my DNP, I would be able to magically sort of apply for a job and be awarded the job. And interestingly, when I was in one of my advisement sessions with Christine Pins, with Dr. Pins, and there either was like a big bubble over my head, and I didn't say it out loud, but Christine one time said to me, you know, Mary Mike, you're not going to get a dream job when you finish your DNP program. What's really going to happen is your DNP is going to help you do your current job so much better. And I have to tell you, she was, as usual, just remember that part. She was on the mark. She was correct. So, let's talk about how you get there and eventually do get a dream job. And it's not necessarily magic. The first thing that you're going to be doing as a student is I'm going to recommend that you leverage your professional experience in your coursework. And what do I mean by that? Well, you're going to be taking something, I think most of you will be taking organizational concepts in nursing. And when we had a discussion about change theory, I pulled upon an experience that I had as a nurse manager when I had to take a surgical tele-unit and modify it into a open heart ICU and step-down unit. And in the discussion, I really pulled on that to say, well, with respect to change theory, this is what I did. And what I know now, this is what I would have done differently to potentially get a better or more expeditious result. Here's another idea. When you're on discussion board, let's say in knowledge management, which I had the pleasure of co-teaching with Dr. Nancy Falk about a year ago, let's say you get a question like this: how can business intelligence tools improve patient care? Well, my recommendation is that you don't simply reiterate what the authors of the articles and book chapters and videos you watched said how they would use business intelligence tools to improve patient care, but rather say, here's what they say. In my setting, in my practice, here's how I believe business intelligence tools could improve patient care. Now let's pretend you have no idea after reading it if your organization even has a business intelligence tool and it's still not clear. I would recommend you do what you normally do when you do not know the answer to a question. What do? You go find your subject matter experts and you ask them. And one of the secondary gains of doing that is that you are showing that you are intellectually curious. You're meeting people in your organization that you may not have interacted with, and you are establishing yourself as, I am a doctoral student and I'm interested in this. Okay. Now, thanks to Dr. Falk once more, she introduced me to Bloom's taxonomy. And Bloom's taxonomy is a way to categorize, it's a way to categorize at a classification system that categorizes intellectual skills and behaviors. And what Dr. Falk taught me in this class that I was supposed to be co-teaching with her was that doctoral students are well beyond the remembering, the reciting, and the understanding phase. The expectation is when you participated in discussion board, you're already at the application phase, applying your experiences to the coursework. And eventually you'll be analyzing large amounts of data or literature. You'll be evaluating evidence-based practices to see if in fact they're reasonable to implement in practice. And eventually you'll be in creating, and by that I mean your capstone project is when you'll be really be creating new knowledge. Okay, so let's talk a little bit about how you leverage your coursework in your own practice setting. And one of the examples that I wanted to use was when you take healthcare enterprise, one of the deliverables was that we had to create a strategic plan. Well, some of you that may be nurse executives may have already created a strategic plan. I never had. And I happened to be in a practice setting as the director of outcomes. It was a new department. So what I was able to do is use the material in creating a strategic plan week by week to create a strategic plan for my department. And I was able to involve the associates in my department when we were going through this process. And I had to find my organization's strategic plan because I wanted to make sure that my departmental strategic plan harmonized with the direction that the organization was taking. And I had to ask my boss where I could find that strategic plan. Okay, are you with me? And when I completed the strategic plan, I presented it to my boss. And what do you think the secondary gain I got out of that exercise? My boss knew I could create a strategic plan. That was not a requisite for the job that I had at that period of time. You with me? Okay. Okay. I had the, I also have had the great pleasure in my role as Director of Outcomes to co-facilitate the heart failure performance team with this physician who's kneeling in the middle of the group, and that's Dr. George Ruiz. He's an advanced heart failure physician at MedStar Washington Hospital Center. And some of the things that we did were looking at our core measure compliance scores with heart failure. So some of you that are in the inpatient setting know that Medicare and the Joint Commission want to make certain that we're meeting these process measures to indicate that we're taking great care of heart failure patients. And some of the strategies that we created were how can we incent nurses to help increase compliance. So the Heart Failure Performance Improvement Team created this George Award, and if a unit in the hospital achieved a 95% compliance with these core measures for a whole quarter, they got an award. They actually got the little statue and they got a plaque, and Dr. Ruiz came, we took pictures, it was publicized and so forth. And I will call your attention to the nurse that's holding the little statue is Dr. Evelyn Awogo, who was a proud graduate of the 2011 DNP program here. Okay. So I learned that the Heart Failure Performance Improvement Team in my organization was a fertile ground to help me leverage my coursework. And one of the courses that many of you will take will be healthcare quality. And Dr. Brenda Scheingold on the faculty here introduced us to the NCQA Quality Improvement Activity Form. And we actually use this in the Heart Failure Performance Improvement Team. I mean, I learned about this at GW, and the next thing I was bringing it to the hospital. And we painstakingly filled out 28 pages of this with very detailed information and with data. And what we learned is that we had missed a very critical point of the work that we were doing in the Heart Failure Performance Improvement Team. Our belief was based on anecdotal information, and what we learned is that was not correct. And in turn, we were able to turn the boat, as Dr. McCausland referred to, turn the boat and regroup and say, you know what we need to do? We need to do X, Y, and Z, and we were successful in doing so. This Heart Failure Performance Improvement Team was also the way that I catapulted into doing my capstone project. My capstone project was on teach-back and the feasibility of using teach-back to reinforce discharge instructions with our heart failure patients to see whether or not it would reduce readmissions. So we talked about how to leverage your professional experience in your coursework. We talked about how to leverage your coursework into your professional practice site. I do want to talk about mentors. And one of my mentors was Dr. Kathy Gazzetta over on the left, and she was my research mentor for my capstone project because I did a small pilot study. And Dr. Gazzetta invited me to come to a meeting one time of the Washington Regional Nursing Research Consortium. Dr. Pintz is a member, and I went there. And it was at that meeting that Dr. Gazzetta said, so Mary Mike, here's what I think. What about you and Jesus Sapiro become the co-chairs of the very first doctoral student conference and networking session? Okay, and that was like, oh sure, okay, that sounds like I really wasn't paying attention. I was telling Christine and I was like, yes, of course, I'll be happy to do that. And this was an opportunity for growth that I had the presence of mind to say, yes, I'd be delighted to do that. Because what that did is that Jesus Sapiro and I, who was a doctoral student, a PhD student at Catholic, we assembled a group of doctoral students who had finished their programs, who were in their programs, who were thinking of programs, and had a collection of posters and presentations about the work that they were doing. Well, that led to me knowing faculty members at the area schools. It introduced me to other doctoral students. It introduced me to people that were also interested in teach-back and heart failure, and it really widened my horizons. The other thing that Dr. Kathy Gazzetta helped me with was when I had taken the course grant writing from that Dr. Kim Acquaviva, Dr. Acquaviva teaches in the summer. When I finished my capstone, Dr. Pinn said, I'd really recommend studying this some more. Well, I worked with Dr. Gazzetta and say, hey, you know what? I saw this I saw this request for proposals. There's a grant out there that we can apply for through the American Nurses Foundation so that I can get some money to maybe get a researcher, a clinical coordinator to help get more participants for me. And Dr. Gazzetta, as usual, oh, great idea, Mary Mike. So go ahead. And I did, and I got it. And I was awarded $10,000 to continue my study, and that was from my mentor and from networking opportunities. Okay. You are going to be doing enormous amounts of reading. Okay. You are going to be distilling enormous amounts of material. And by the end of your curriculum, you're going to do it really well. And you're going to know exactly what you need to read, and you're going to be able to say, that's not what's going to work for me. That article's not going to work, and it's going to give you the confidence to do that in your current work setting. And for me, what that meant is it gave me the confidence to go through something that's called the Federal Register, and it was at least 1,500 pages of federal government speak that had to do with where the country was going with value-based purchasing and what that was going to mean for our particular hospital in terms of reimbursement. And because I had the confidence and the experience of going through as much information as I had in this course, I was able to read through that and eventually present that to some of our executives. After presenting to our executives, they said, Mary Mike, you know what I think we need to do? We need to have a metrics team. Can you co-chair that? Absolutely. And then I was invited, because it had to do with readmissions and patient satisfaction, I was invited to be on the patient satisfaction task force that included the CEO, the CFO, the COO, and the CNO. So imagine the secondary gain I got from that. So I learned how to read all those materials in this program and had the confidence that I could read just about anything and untangle it, and it got me incredible visibility in my own organization. So where did that eventually take me? It took me to what Piper and Colwell talk about, being able to cultivate an openness to new ideas and a vision of what could be. And my belief is that that the culmination of being able to leverage my experience in my coursework in my practice setting, and evidence the things that Dr. McCausland talked about in the blueprint. That's what led me to be promoted about 6 months after I graduated to Assistant Vice President for Outcomes and Quality. And a year later, I applied for the position I'm in now, Vice President for Nursing Practice Innovation at the hospital system, 10 hospitals, the VNA and so forth, and loving every minute of it. Okay? So, here's our prepared questions. How will organizations leverage the non-clinical skills of DNP-prepared nurses, e.g. administration, quality improvement, or education? And I think I might ask you to speak to that, Maureen, if you don't mind. You might need to hold this little guy, if that's okay.
So when Mary Mike and I were looking at these questions, she pretty much had an idea about what I would say. I'm going to turn this around a little bit. What do you guys say? think of them as non-clinical. I think for executive nursing practice, they're part of the toolkit. So when I was a doctoral student at Boston University, I was in the nursing administration cognate. And in order to be in that program, the assumption was you had all the coursework for the master's in nursing administration, and my master's was a clinical master's. So I had to take all the prerequisites for the program, one of which was accounting, one of which was finance, one of which was human resources and healthcare. Those courses served me very well. And then as a teaching assistant in the doctoral program, I was assigned by the department chair, Muriel Poulin, to really be the nurse faculty content person in all the finance courses. Those finance courses were taught by the chief financial officer from Boston University Hospital. But Muriel's vision was that there would always be a nurse faculty member in the room to do that translation. So yes, they might look like business courses, but I would encourage you to think of them, particularly those of you in executive practice, that they really are part of your practice environment. And then the second question that I'm going to answer is, do I foresee the DNP as a requisite for nurse executive positions? I think that the context is important. So clearly in academic health science center services and academic health systems, I think this is absolutely critical to success. I think the complexity really requires the types of things that we've talked about here. But I don't exclude it, in my mind, of thinking about a DNP degree for other nurse executive positions. So across our organization, everybody has to have a master's degree to be a CNO. There's just no question. But we have at least 3 people on our nursing executive council, 4, who have an earned doctoral degree. So I think it's really important information to bring to a position, and I think that depending upon the organization, they might make it a requirement to have a doctoral degree, or they're open to people coming in and when they're interviewing, talking about what it is you learn in a program like a DNP that really brings value to that organization.
One of our DNP students asked, how should I start building a professional portfolio to be more competitive in my work environment? And I hope that you leave here today realizing that you don't check off a box. Some of you might be more goal-directed and might be more intentional than I was. I just found myself saying, yeah, let me try that, or yes, let me apply my coursework. And I found that when I did that, and as Christine predicted, I started to do my own job that much better. I'd also kind of ask you, when you think about a portfolio, am I hitting the mark on what you believe is a professional portfolio? Like accomplishments or, okay. And how do I convince my direct supervisor of the value and importance of the schoolwork I bring to the workplace? Okay, so I would approach this in a couple different ways. One of the things that Maureen and I talked about, and Maureen said, gee, I wonder if this has to do with what's the educational preparation of the person's supervisor, and if they value an advanced degree. And if that's the case, and if that's the feeling, I would recommend having that conversation with your supervisor and talking a little bit about what you anticipate that, while you're doing it. And if it's, you can even just say, it's for my intellectual, it's for my intellectual challenge. I'm a lifelong learner. I love to learn. Okay. On the other hand, if your supervisor was like the one that I had, who was, very interested in finding out what I was doing, you're in a different place. It just happened to be that the person that I was reporting to was also a doctoral student. So I was very fortunate. And in fact, she was a doctoral student not at GW. And when she saw what I was doing, she said, gee, I should be taking those courses. I'm not getting that. I'm taking, she was taking other courses. So I was like, good, yep, you're right. I'm enjoying what I'm doing. And lastly, if really the situation is that your supervisor is really questioning how you're spending your time, that's a completely different conversation, because that's something that you need to talk about immediately. If your supervisor's belief is that you're bringing schoolwork and she or he is paying you to do your schoolwork, that's something that you have to straighten out immediately and clarify. Okay, I think that's it for our questions. How about some questions from you? Yes.
First question, what do you go by as far as title? There's been some debate about, DNP prepared person at the workplace and patient confusion. And then second, how can we help our peers to not feel threatened, because there's still some of that out there about nurses going on in education. What can we do to make it exciting for them as well?
So what do we call ourselves? How do we explain ourselves to patients, and how do we reassure others that that we're not? Okay. Well, I'll answer the first part, and I'm going to invite Maureen in to comment as well. One of the things, and you'll notice I've sort of segued into saying Dr. McCausland, Dr. Falk, Dr. Pence. One of the things that Maureen did very early on, I noticed, is that she introduced me to everybody. This is Dr. Mary Michael Brown. Dr. Mary Michael Brown did this for me. Dr. Mary Michael Brown is going to lead this discussion. Dr. Mary Michael Brown, without any apology whatsoever. Now, I don't take care of patients directly. What I've heard from some of my nurse practitioner friends is that patients, it's a very blurry line to patients. If the nurse practitioner is taking exquisite care of them, sometimes spending more time with them than the physician, and you're a nurse practitioner, what do patients end up calling you anyway? Doctor. Didn't matter if you had a doctoral degree or not. They think of you as, you're doing things that are advanced practice activities that they call doctor. Now, I don't have any experience in the clinical setting of having to arm wrestle a physician who says, I don't want you to be called doctor. But I would invite Maureen to comment on the concept of calling yourself doctor, using doctor title.
I think you covered it.
Mm-hmm.
I mean, I think it's really important that it's just factual. And as a graduate, you have a doctoral degree. And psychologists have a doctoral degree, and some of our pharmacists have a doctoral degree. So, I don't want it to sound flippant, but we shouldn't make it an issue. It is what it is, and it's just factual. And it's, in our organization, for example, our CEO is really very proud of the fact that we have doctorally prepared nurses. He views that as a competitive advantage when he's out talking to other system CEOs around the country. We have a newsletter, and last year was the first. We were playing a little bit of catch up. But there's a whole section in our first edition that has the accomplishments from 2011. It is single-spaced, it is multiple pages. And our board was absolutely thrilled. And the members of our corporate executive team were really very proud, because they might have known a little bit about what nurses were doing, but when they saw all the poster presentations, all the publications, all the professional service that people did, it was, really quite well received, and people were happy that we were collecting it and sharing it with people very broadly.
And if I could add one more thing to that, the other thing that I noticed too is that I didn't originally work in a department of nursing when I was going through the doctoral program. I ultimately reported up through the chief medical officer's group. But it was always astonishing and gratifying when nurses who I knew in the hospital, Dr. Brown, they were very proud that they knew somebody, a nurse that had achieved a doctoral degree, and they were the ones that wanted to insist on saying Dr. Brown. Other questions? Have we completely?
Can I ask a question?
Of course, Dr. Pence.
Yeah, I have to say, life became different when I became Dr. Pence. It really not only feels good, yourself, just knowing that you've achieved it, but you're definitely part of the club at that point, and so it's important to be kind of at the same academic level as your colleagues. And this is a question that I've gotten asked, and so I'm just curious to know what you think. What do you think about sort of the difference between a nurse getting an MBA and a nurse getting a DNP, and with maybe a focus on executive leadership?
Well, I mean, it was something I thought about in my career. I had a clinical master's from Boston College in community health, and I was very fortunate that I had an instructor my senior year who really talked early and often about the fact that we should think about doctoral education. And you know, it was sort of a newer concept to be talking about that to baccalaureate seniors. So I looked at it long and hard because I love executive practice. But what I really decided, being very practical, why would I get a second master's degree? I already had one. It was a robust degree. It has served me very well in terms of thinking about patient populations and health policy and those types of things. And secondly, I do really believe, and I couldn't articulate it when I applied, but I do believe there's something different about leading a professional practice discipline. Because it's, you know, you don't order people to do things in a profession. You really engage them around a compelling vision and moving towards excellence. And if people don't want to be on that path, they sort of self-select out perhaps of different roles. But I think really understanding what it means. So in my program, we spent a significant amount of time on nursing theory. And then in the administration cognate, we actually wrote an additional paper that many of us thought might have put us a year behind on comps, but because it was pretty robust, and we had 3 members of the nursing executive community come in and critique every presentation. But what we were charged to look at was how we would take those conceptual frameworks, theories, mid-range theories, and apply them in practice. So much like Mary Mike talked about, I took Newman's systems theory and we implemented that as our framework for practice and documentation at Boston Department of Health and Hospitals, because I was the director of community health nursing at one point. So it had real practical application. And it was not esoteric. So there's absolutely nothing wrong with an MBA, and I don't want people to think that, but I do think the nursing framework and umbrella really is what we need in contemporary practice.
I have a question. It's such a great opportunity to have, you know, both of you, here. And this is a little outside of the realm of, you know, the DNP specifically, but if we were to look into the future in terms of nursing, you know, like 5, 10 years out, with all of the changes in the healthcare system, you know, with all of the changes in education, now, what do you really see as the future of nursing?
I think this is a really important question. I've been thinking about it a lot because there's tremendous work in our organization, and I think in lots, to look at how we do population health. How do we help patients and families across the continuum with the right amount of care at the right time? What makes me a little bit nervous is, you know, thinking back to one of the cycles that we've gone through where many of my close friends and peers were saying things like, the bed is dead. You know, I was practically levitating when somebody made that comment at AO&E. I don't think we are going, what we're seeing right now, and that gets into this futuristic perspective, we're seeing it at MedStar, and our CEO was at a national meeting with other system CEOs, and I was at one with CNOs. Our census for inpatient care in community hospitals is going down, down, down. And our census in the academic medical center in our system, so MedStar, Georgetown University Hospital, they're absolutely filled to capacity every day. And if I look at volume at our very large, complex teaching hospital, MedStar Washington Hospital Center, also very full. Evidently, this is happening around the country. So, you know, who can understand all the nuances of that? One, taking the high road, you're thinking, well, perhaps patients are finally getting care at the appropriate level and they don't need to be in the hospital, or there's a variety of other things. So I think there is a tremendous opportunity for nursing, and I hope that we don't ever stop thinking about the hospital, because the hospital will always be there, and I think we'll always need competent and expert nurses and leaders, but there's this whole new emerging arena of places for nurses to practice where we're going to need them. I had been sharing with Dean Johnson, we're recruiting for nurse case managers for MedStar Medicare Choice in the District of Columbia. I think these are wonderful jobs. They are really difficult to fill. And I think unless somebody has had an opportunity to interact with a nurse case manager, it doesn't sound very interesting perhaps. And there's clearly a skill set that the nurses doing that practice need. So I think those opportunities are just going to continue to develop. Does that sort of get at what you were thinking about, Jean?
It does.
Yeah.
You know, and all the work that you're doing around transitional care and even those kinds of things. I mean, I think that absolutely. I don't think that is dead either. Yeah.
No, and you know, if I'm ever in one of them, I'd like to have an expert nurse around.
Smart nurse to take it.
Yeah, I think in our world, the complexity at the Washington Hospital Center and MedStar Georgetown University, they really are continuing to be large ICUs. And what we see in our system is that patients who are on general care or specialty units in those two organizations are in the critical care unit in our community hospital and sometimes waiting for the helicopter to come and move them out. And we want to do a better job of moving them when they need to be moved. But.
Thank you. Sure. Other questions? Yes.
Yes, as the PhD has traditionally been sort of a revered degree for a faculty in academia, how do you think a DNP for a faculty will change the academic practice environment, thus trickle into the clinical practice environment? How will that change the landscape of academia?
Well, I might ask our faculty. So, Nan?
Yeah, let me take a crack at that. You know, at GW, and we're not certainly alone, but we value both DNP and PhD faculty. We don't differentiate. DNP faculty is as eligible and appropriate for a tenure track position as a PhD. You know, everyone is expected then, you know, to do a substantial amount of scholarly activity. You know, and the scholarly activity is really focused in a way that, you know, both Maureen and Mary Mike have described, you know, because there are differences, but both really, really important. You know, there has been concern, you know, within nursing in terms of will all the interest in the DNP stifle interest in the PhD, and there's really not very any evidence to suggest that at the moment, you know. But there are programs that are, you know, being initiated to really continue, you know, sort of interest in the PhD. But I think that there's going to be a very robust opportunity for DNP prepared individuals in academic institutions. And if you look at, like, for instance, the PharmD, you know, and also the doctorate of physical therapy. You know, whereas people, you know, in those areas used to get, you know, sometimes PhDs or EDDs or something of that sort, you know, within each of those disciplines, once the degree had been sort of defined, the practice degree, even people who had gotten other degrees had sort of thought about going back to get the, you know, doctorate of physical therapy or PharmD. So, you know, this is going to take a decade to shake out.
Other questions? Well, Maureen and I want to both wish you every success in your program, and I know we'll be looking forward to hearing about your progress. And we have lots of projects for doctoral students at MedStar.